Hello, and welcome to Glom Goals, a podcast from Arcana Laboratories about renal biopsy adequacy. I am Sri Sharma. I'm a kidney pathologist here at Arcana Labs.
Hello, and I'm Tiffany Keza. I'm also a kidney pathologist at Arcana Labs.
Today, we are going to be meeting with Dr. Salil Parikh, a radiologist with the Methodist Le Bonheur Healthcare Group in Tennessee. Dr. Parikh is with us today to provide his insights on mastering the kidney biopsy, as his practice has achieved excellent biopsy adequacy. Tiffany, what is excellent biopsy adequacy?
So kidney biopsy adequacy overall has been declining over time, and this is impeding diagnosis or clinical decision-making, and it's resulting in unnecessary repeat procedures. Overall, 24% of kidney biopsies are inadequate across the United States, and this has been declining over time. I would define an excellent kidney biopsy in one that receives accurate diagnostic information, and also that has primarily cortex with at least 10 glomeruli available for evaluation. And 10 glomeruli is what can be used for multiple scoring systems, such as scoring of allograft rejection or IgA nephropathy or lupus nephritis that would provide an adequate enough sample. This prevents requirement for rebiopsy and also gives good prognostic information by having information such as the degree of glomerulosclerosis or IFTA. And so we really look forward today for having Dr. Parikh with us to give some insights on his best practices and also how others can have similar success in achieving optimal biopsy adequacy.
Thank you, Tiffany. And anyone who wants to know more details about what Tiffany just said, go and listen to our previous podcast. So, Dr. Parikh, welcome today at our podcast. To start with, could you tell us a little bit about your background, where you train, and how you found your way into radiology?
Yeah, sure. I trained I went to the University of Tennessee in medical school back in the 90s, a long, long time ago in the dinosaur days. And after that, honestly, I had no exposure to radiology, and I was an internal medicine resident when I finished medical school. But during my first year of internship, by luck, I just happened to have an elective in radiology, and not having much exposure to it, I jumped into it. And after that month, I realized that I loved that month. It was great. I enjoyed the intellectual challenge. I enjoyed the deductive reasoning that was involved in radiology. So I made a decision at that time to change and move into radiology. And fortunately, I was able to get a spot in Memphis at that time, the following year, and haven't looked back since. So it's been great. It's been a great journey. So yeah.
That's great to hear. When did kidney biopsies first become part of your practice, and what drew you to mastering this particular procedure?
So that's really interesting because I tell you, when I was in residency, which again was in the 90s, we did not do any renal biopsies. It was really done by the nephrologists at that time, and I had no experience doing kidney biopsies. And it was only after I actually moved away for 5 years to Florida, was working there, came back to Memphis. And Methodist Le Bonheur Healthcare started a transplant program. And that was probably 2010, maybe, that they started that 2009, 2010. And it was after that we started doing kidney biopsies. And really not having a lot of training and just kind of doing it like everybody else was doing. But what had happened was that we were getting, our adequacy rates weren't very good at that time. We were getting complaints from the nephrologist. So that's when we started investigating how to improve our adequacy rates. So really, it was more on the job training more than anything else. It wasn't any kind of simulation, or it wasn't even actually any kind of supervision. It just kind of jumped in and just started doing it.
That is great to know, Dr. Parikh, because you switched from medicine to radiology, and within radiology then came to kidney biopsy. Do you think kidney biopsy is a different skill set, or do you think every radiologist should have that in their toolkit?
I think the people that are doing procedures, and honestly, I am not an interventional radiologist. I'm a body imager. That's my fellowship training was in body imaging, but I do in my practice, we're the ones doing all the biopsies and all the abscess drainages and all the stuff that's done under image guidance, under CT and ultrasound, and interventional radiology handles most of the vascular work. I think if you are doing procedures, I think this is definitely should be part of your skill set, and it's really not that difficult once you get over the initial hump of learning how to do this. I realize that we have people in my practice who are in the periphery, and you can make an argument that people doing biopsies should be doing a lot of them. I definitely get that, but we're in a situation where some of our peripheral hospitals where they are asked to do kidney biopsies on inpatients. They can't transfer them anywhere. They have to do them there. And just by education, they've actually gotten really good at it, even though they don't do that many biopsies. They're actually pretty good at it. So I would say if it's possible, yeah, it should be part of every radiologist who does procedures. If you're doing procedures, I think this should be part of your armamentarium.
Dr. Parikh, you brought up that your practice had originally had difficulty with biopsy adequacy, and that you dived into why this may be happening for process improvement. Can you tell me a bit about that journey and how you guys achieved better adequacy rates?
Yeah. So so what happened? I think I realized that in residency and in training, really kidneys are really kind of thought of like any other organ when you're doing a biopsy. And I think that's where the fallacy is. And there's a proper training isn't there. The kidney is it's different from biopsying the liver or biopsying and the adrenal gland or a lymph node or something else or a lung mass. It's just it's a little bit different. And I don't think that is really taught. And I wasn't taught about that. So I kind of did a deep dive into that thing, started doing some reading, and there was an article in 2010 by Patel from Scottsdale, Arizona, Mayo, and he had an article that talked about using the tangential approach for kidney biopsies, and that is what really changed. After I read that article, I was like, "Huh, this is the way that we should be doing biopsy," and it made sense. And I read the article like this completely makes sense. This is the way we should do it. You'll end up getting more cortex, which means you'll get more gloms, and your risk of bleeding goes down. So I saw that. I talked to my other radiologist, and I said, "This is really the way that we should do it." So that is what we started to do. I can tell you the process that we started when we did that. What I started doing, and I think this process really works, is we would gather all the pathology reports, and we had somebody, one of our techs who was involved in quality, and they would basically create an Excel spreadsheet every 2 months, and they would list what everybody's adequacy rate was by patient. So you get an Excel spreadsheet, and if one person did 10, one person did 5, there would be a list of all the patients by their medical record number, and it would be a column of how many gloms that they had. And what's good about kidneys, it's really very much for us. It was very much black or white, and we made 10 our cutoff. So if it was below 10, it didn't pass. If it was above 10, it passed. And what really helped was that everybody knew how everybody was doing. And I think we in medicine, we have that competitive instinct, and I think that's what really helped. And what I would do is every 2 months when we would send that spreadsheet out, I would look at the scans I would look at the procedures that were not adequate, and I would take pictures of the CT images with the needle at the kidney. And I would tell you that probably about 85 to 90% of the time, when I looked at those images on the inadequate cases, I could look at it and say, that if you had used a different approach, you would probably have this would have been adequate. So what I would do is I'd get a picture, it'd show where the needle was, and then I would draw a needle on and say, hey, this would be a better approach. And I think over time, people bought into that, and that's when our rates started getting above 98, 99%. And I think they pretty much stayed there right now. So, but yeah, that's kind of how it did. It was kind of a game that we would play. Every once in a while, we'd have somebody that would have only get one or two glomeruli, and we would give out a what I called a Febreze award, because we'd say that biopsy stunk, so they would get A for And so we made a kind of a game out of it. Didn't want to anyone's feelings, but I think people accepted it, and it's taken off and done well.
So I love what you said about technique. So you mentioned tangential technique. There are some other things which I have heard are important. So you tell me whether those things are important or not, and what else to consider during a biopsy. Like I know that targeting lower pole is important, and now we have a gun which gets fired, right? So firing the gun at the capsule is important so that we don't go down deep. And I can see importance of the tangential technique, because if we don't do that, we will end up hitting major blood vessels actually. So what else is important from the technique perspective to improve adequacy?
Yeah, I think it's really an attention to detail, and what I realized is that you really need to do it the same way every time, and get into a habit of just doing it the same way. Lower pole is good. I don't always go lower pole. Sometimes it'll be mid pole, just depending if there's bowel in the way or such. I try to tend to go lower pole if I can, but it's not that's not mandatory by any means. But I think the main thing is that just being just doing it, being uniform in your approach and doing it the same way. Little pearls I've learned. Some people would for the native biopsies, people would hold respiration, practice breathing. I did that initially, was doing that, but I realized that even without any of those instructions and just let them breathe freely, I was still getting good biopsies. And I think part of the reason why is maybe because they're lying on their stomach, they're already prone, they're really already shallow breathing to begin with. So the little approaches like that I had changed. On the transplant kidney biopsies, they're generally supine when we do those. We also don't breathe those patients. One issue that we were having, that some of the patients are very large, that we have in our population here, and one thing that I also learned is sometimes it's good to put them on their side. You put them on your side, it will actually move the fat and move their bowel out of the way, and that distance that you're going to the kidney actually shrinks a lot. So some of the patients, honestly, what I do now is when I examine them initially, if they're fairly large, I will already start them on their side, and just and do the biopsy that way. But yeah, the tangential approach is the way to do it.
It sounds like you tailor that nicely for each patient. Over your career, Dr. Parikh, has that technique changed over time based on equipment or imaging modalities?
Really, it hasn't. We do it under CT. I think like most people in radiology are probably more comfortable with CT. The other issue that we were having with ultrasound, what we saw was that we have a transplant nephrology department. Every once in a while, they'll have transplant fellows, and they would, for the fellowship, they needed to do X number of biopsies, and they would do those under ultrasound. But what I found is that half the time they were not able to do them under ultrasound because of the patient's size, bowel in the way, and they ended up having to switch over to CAT scan. So that's why part of me is just like, let's just start off with CAT scan to begin with. I've never ever had that issue of trying to switch over. And if it's an outpatient, it does become a little bit of an issue, because to switch from ultrasound to CT, at least in our department, you have to get another order, and that's kind of a big deal. It often annoys the referring physician because it bothers them. So we do everything in CT. Also, when we started getting CT fluoro, that was something else that we added. CT fluoro, which is more real time biopsy, that does speed up the biopsy in certain cases. We don't have that at every hospital, but at the two main hospitals that we do our kidney biopsies, we do have that, and I do use that on a routine basis.
I have two questions, Dr. Parikh, and they are related kind of a thing. So you gamified the system. You had a dashboard where the number of GLOMs were listed. So how did the radiologist take it? And during that process, did you find that doing minimum number of biopsies is important for competency? Like people who were doing more biopsies were more competent, people doing less biopsies were more competent. Did you find any such relationship?
I honestly, this may be a little contrary, we did not. Some of the doctors we had doctors in the periphery that were being asked to do biopsies, like I said earlier, and their adequacy rates were just as good, actually, if not better. and maybe they were paying more attention to their technique, and but I did not see any difference between the ones who just did a few compared to the ones who did many. I did see a little bit of a difference between the body imaging people and the interventional radiologists, and I hate to say this for my interventional radiologists, but sometimes their adequacy rates tends to be a little bit lower for the interventional radiologists. I don't know what exactly the reason is. Maybe it's just really busy and it's not paying quite as much attention to detail. That was just a small difference. But overall, yeah, I guess you would think it would be the opposite, but I did not, in our practice. I haven't seen that, and I really think what it is. Is just training, getting that training, and just getting a few under your belt, holding people's hands, and getting the feedback. It's really, really important to get that feedback later on. Get that path report and see how many glomeruli you got, and that's how you can figure out whether you're doing a good job or not.
So technique you mentioned. So overall, your practice is doing such a great job. So who does the training? Like, do you do the training, and or is it done by everyone? Everyone is teaching each other, and is that technique variable from person to person, or it's pretty much uniform throughout the practice?
We've pretty much made it uniform now. I think pretty much everyone is doing it tangentially. Again, when I was sending out those reports every 2 months, and then my first blurb would be, "Look, this is how I do it. I use the tangential approach. Put two specimens between 2.3 and 2.5 centimeters in formalin. Put another specimen 2.3, 2.5 centimeters in Michelle solution." And I would say that every 2 months, the same thing over and over and over again. And then again, show examples of biopsies that were good, and show examples, actual pictures, because radiologists love pictures. And I'd show pictures of cases where they weren't ideal, and then I would show how a different approach would have a better chance of getting an adequate sample. Most of the teaching, we do have a residency program here, and so there's a group of us that teach most of the residents. But since we've introduced this tangential approach, that's the approach that we teach all of the residents also. So I'm hoping when they all get out in practice that they will continue to have good adequacy rates.
Do you think there's a number of procedures that's needed to gain proficiency for the residents or new physicians joining your practice?
Yeah, just throwing out a number, honestly, probably 10 is what I would say. If you could do 10 cases with the supervision, I think that's probably enough. Cases, just using that tangential approach and just getting used to that, and being really compulsive about doing that correctly, is really all it takes. Now, I say 10, but again, some of my doctors in the periphery have had fewer cases than that, and they still did a good job.
Dr. Parikh, what is your take on needle gauge? Because this is an active debate going on. So what is your take on that?
Yeah, well, as you know, radiologists, we're just used to the 18 gauge needle. Everything we do is using an 18 gauge. I know in the nephrology literature, 16 gauge is the way to go, and I've toyed with that idea. Actually, we've gotten some core biopsy guns that are 16 gauge, and I may try and do that. Again, the hesitancy is the increased bleeding risk, which I know the literature says that there is not, but it's just kind of a mental block to get over that. I don't know if I can get buy-in from my other radiologists, to be honest with you, to doing a 16 gauge. But I actually have ordered some, and I may actually try to do those. And if I get good specimens, I may suggest to my other partners, and maybe they should try that. But it seems to me like we're getting pretty good adequacy rates even with an 18 gauge needle. So
yeah,
when I talk to my nephrology colleagues, they all seem to be very happy with
yeah.
So
I agree.
Do you have any needle types or brands that you would recommend?
Yeah, we have two that we use. One is Biopence, and the other one is called Corbicet. Biopence I was using for a long time. I've kind of switched over to the Corbicet. I'm getting really good biopsy samples with the Corbicet. It makes less of a sound. Biopence is kind of a spring-loaded system that's kind of loud. But yeah, those are the two that I use.
Do you have any algorithm for the number of courses or number of passes which you take, or how do you balance that number of passes with the risk of bleeding?
Right. Yeah. I generally what I try to do is I do a 2.5 centimeter throw, a 2.5 centimeter length sample. I'll do two of those and put those in formalin, and then I'll do one 2.5 centimeter sample and put that in the Michelle solution. I will look at the sample if it doesn't look correct, and sometimes it happens. I'm in the periphery and I just end up getting mostly fat. And I can tell when you put the sample out. This looks like it's mostly fat. If I have any question that the sample is not adequate, I will go and do another biopsy. In my experience, I have not seen an increased bleeding risk with that. So I think that the tangential approach is really safe. It's really safe. I have had instances where I've had to do 3 or 4 of them to get the adequate samples and have a significant bleeding. I haven't seen it. And I think almost every kidney does bleed some after we do the biopsy, but we routinely do not get imaging afterward of these patients. We only get imaging once they're downstairs in holding in recovery, and if they're having something unusual, pain or something that's just doesn't seem quite right, then we will bring them back up. But I tell you, it's few and far between.
Okay.
Do you have someone there with you to help with assessment of adequacy? Is there a pathology technician or dissecting microscope?
Yeah. Unfortunately, probably like a lot of places, we don't have the staff for that, and pathology does not. They don't come down. That they stopped doing that many years ago. So we're really have to kind of make that decision on our own.
So how did you learn, Dr. Parikh, to look at the tissue? Because this sounds very simple, but I have seen many places, they want someone on site. When they look at the tissue, they don't see it as cortex, medulla versus fat. So how did you taught yourself and everyone else in the practice?
Yeah, it's just again, it was looking at the sample and then getting follow up on the path result. And you look at the sample, and over time, you get a good feel for what it should look like. If you see the little dots, the little red dots in that sample, then it's probably a good sample. And again, and I can't emphasize this enough. You have to go back and check all the path results. It doesn't take very long to do that, but that's what we do: is go back and look at every one of them and see how many what the numbers were. And with that correlation, you get a pretty good feel for what's a good sample and what's not.
So you mentioned that in your practice that you don't have many bleeding complications, which is wonderful. How long do you observe your patients post-biopsy to ensure safety and that they don't have bleeding complications after?
Yeah, we keep people for 3 hours after the biopsy. We let them know from the front end. This is the system. Once the biopsy is performed, you'll go downstairs in recovery. You'll say 3 hours, everything is okay, and then you can go home. And again, we don't get imaging, post-imaging afterward, just unless something seems unusual. We don't get that. And I'll tell you, on my transplant biopsies, I think I may have had one significant bleed. I mean, I've probably done 1,000 of those, and I probably have had one significant bleed. The ones that have had more significant bleed are the native ones. I can probably count on one hand the number of significant bleeds that I've had. I probably have had 2 or 3 of them that have had to go to angiography to get something embolized. But again, I think compared to the numbers that we do, it's still pretty low.
So, Dr. Parikh, you have covered the technique, you have covered the management before and after the technique, you have covered the adequacy as well as what to do it. So when you see people who join your practice or you interact with trainees, can you tell me the gaps in the training which are there right now, how can we have more and more people learn how to do a proper kidney biopsy?
I think with every practice, you need to have a champion. You need to have somebody who takes ownership of this and says, "Look, I'm going to teach everyone how to how to properly perform a renal biopsy." I really don't think in training, residency training, that is really taught. I think, again, like I said earlier, it's just a kidney biopsy. It's just like any other biopsy. I think that's what we're told. And the tangential approach is, again, it's just, I don't think people know very much about it. So really what you need in any practice, and in our practice, is that you have one person who's a champion who tells everybody, hey, this is how you're going to do it. And again, the feedback really helps because anybody who does a renal biopsy everyone is going to know what their success rate is. And again, we're appealing to people's ego. When you do that, people are going to know. And if your adequacy rate, if it's not there, if it's under 10 gloms, then everyone's going to know. And again, it really appeals to their competitive aspect that people want to get better when they see it out in public. So that's what we do. When we have a new person come in, we will train them if they're involved. Not everyone is doing biopsies. Not everyone in our group does it, but the ones who are doing procedures, all of them, with the expectations that they'll be doing a renal biopsy.
So when you look at the biopsy at the bedside, do you use any device like a phone, microscope, or just naked eye?
Naked eye. Yeah, we just look at naked eye and look at it, and that's it. I'm really interested in the smartphone idea that you have. I think that's great. Once that's perfected, I think that would be of great help. But again, I think as long as you're compulsive about making sure it's tangential, you're looking at the image, you know where that needle is. You can get good samples. Well, I tell you, one little pearl I've seen in some people is that they would actually put the needle into the kidney when they're doing a biopsy, and I've emphasized don't do that. Put the needle right outside of it, because you're missing a little bit of cortex when you actually do that. And some of these native kidneys, it's impressive how thin the cortex really is. That's something else I teach our residents too, is that look at a normal CAT scan on patients who have renal insufficiency, and look at the cortex. You can see the cortex on those scans when they give them contrast, and see how thin it is, and say, remember that when you're doing a biopsy. You can't go in very deep, because you'll end up getting mostly medulla if you do that.
How does your procedure vary between native and transplant kidneys?
A little bit of difference, I guess, for the native kidneys. I try to get closer to the lower pole. For the transplant kidneys, I will do the upper pole. Our transplant surgeons have told us that they don't really want us biopsying the lower pole of the transplant kidney, and their reasoning behind that is that if there happens to be a bleed, if you do a lower pole biopsy on a transplant kidney, if there happens to be a bleed, then they would call interventional radiology to come in and embolize that bleed, and they will try to super select the vessel to try to minimize the amount of infarction in the kidney. Unfortunately, what could happen is that what they tell me is that the vessels that feed the ureter come off the lower pole of the kidney, so there's a higher chance of developing an infarction of the ureter from a hypothetical standpoint. So because of that, they don't want us biopsying the lower pole. So we only biopsy. I try to go as upper pole as possible on transplant kidneys. That's probably the only difference.
That's interesting.
Yeah.
So it seems like you have a great training program in your practice and really improve each other. You can tell that you have a good work culture just talking to you, because people have the vulnerability to see their inadequacy rates among their colleagues and that competitive nature to get better. For the next generation of radiologists, what should we focus on to keep these kidney biopsies precise and safe and impactful?
Again, just really the attention to detail, particularly using, I can't emphasize this enough, that using that tangential approach and getting educated on using that tangential approach, and that may be something that you all as nephrologists can also get out to people doing biopsies that use this tangential approach. Maybe have an article out there that can show it again. What really inspired me was this article I read from 2010. Again, out of Scottsdale, Arizona. But I would emphasize also to my residents, and I tell them that you are making a difference. It is really important to get this biopsy done correctly, because it is a patient, and depending on how adequate your biopsy is, that is what's going to help the nephrologist determine how to treat that patient. So you are making a difference, and it's really important to make sure that you do get an adequate sample.
So a couple of things I'm thinking. It is important for us to train everyone in radiology how to do a biopsy. The way you did it, the gamified, and everyone's performance was there on the dashboard. How about having such a dashboard for the entire country? So every radiologist. How do you do that?
Yeah, I don't know how to do that. I think the problem is the bandwidth behind that. How do you spend the time to do it? It's great. thinking about that, but who's actually going to handle all that? And I think that's where the challenge will be. I tell you, for radiologists, not only showing the numbers, but I think radiologists showing pictures are really important. I think if you can show, hey, here's an image that was not ideal. Here's an image that is ideal. I think that really helps. They can see that it's like, oh, this is the technique I've been using, and that I can see now that's not perfect. That's not the best way. But this other picture shows a different way, and that's how I'm going to start doing it. So I think that is really what has helped in my practice. Not only showing the number of glomeruli people have had, because once they see that, they still don't like, well, what should I do different? What am I supposed to do? I only got 6. What am I supposed to do? Well, now I'm showing a picture. I go, well, on this case of 6, this is how you did it. But if you really wanted to get 10 or more, or 15 or 20, this is how you should do it. And you've got a much higher probability of getting an adequate biopsy. So I think that's what really helps. And I think that's great, trying to form some kind of registry. I think the challenge again is it just seems like a lot of work.
Yeah, I agree.
Dr. Parikh, if you were to give one piece of advice to a young radiologist or nephrologist about the kidney biopsy, what would it be?
Yeah, I can't emphasize enough that you are dealing with a patient, and your biopsy has a life of its own in terms of how it affects that patient. So again, like I said earlier, it is important to remember that your adequacy rate will help determine how the nephrologist treats that patient. So it is really important to learn this approach and do it correctly, because again, you are making a difference.
This is a great point, Dr. Parikh, which you mentioned. And understanding the difference between success of the procedure and getting a diagnosis on the biopsy. Because we might end up getting a diagnosis even on an inadequate and a bad biopsy with a 1 gland. But that was not a successful procedure. So understanding the difference between the successful procedure and getting a diagnosis or not a diagnosis is important. So I like your point.
Yeah, I think again, I think what needs to be done is there just needs to be one person who kind of champions this thing in every practice, and I think that's what you need is kind of a point person who's willing to spend some time doing this. It's not a lot of time. It doesn't take that much time to do this, but just to teach your other colleagues how to and just keep up, follow up with the data. But I think what every practice should be doing is, again, keeping a spreadsheet of people's adequacy rates, and I think that would be very helpful.
Okay.
If they have the proper culture to do that.
I agree with you. Culture is very important. And you have highlighted the importance of precision and teamwork behind every diagnostic biopsy today.
How, as pathologists, can we help you radiologists or nephrologists performing kidney biopsies achieve better adequacy? We can provide data on the number of glomeruli and data on the biopsy, but you mentioned needing a champion in each practice. And is there anything we can do as pathologists to help encourage this?
I think what you're doing just through these podcasts and everything is excellent. There's got to figure out a way to get the word out to other radiologists, because it seems to me, I think most of the biopsies nowadays are being done by radiologists. I don't see that changing. I know there's probably a push from some nephrologists to do that, but in my practice, I don't see that at all. They would rather us do the biopsies for various reasons: time, reimbursement, and so I don't see that changing. But I think what y'all are doing is great. It's getting the word out. Perhaps even with different groups that you all can kind of start forming this thing too. Maybe you all can have some kind of competition, between maybe different quartiles or something, and say, hey, your practice is in the top quartile of adequacy rates, or your practice is in the bottom quartile of that. And maybe if they got that word that, hey, we are not doing such a good job compared to everybody else, again, using those competitive instincts, maybe that's a way to improve it.
This is a great idea. I love it. I think we covered a lot. Anything else do you think, Dr. Parikh, we are missing we should cover today?
No, I think that's about it. Yeah, I think this is exciting. I appreciate the work that you all are doing in getting the word out. I did not realize. I listened to your other podcast. I did not realize that the inadequacy rates were so high. But I'm optimistic that is something that can be rectified.
Yeah, we'd like to thank you, Dr. Parikh, for sharing all of your insights with us today. You're helping us appreciate the precision and teamwork behind every diagnostic kidney biopsy and the insights from the great job that your practice is doing.
Well, thank you. Thank you much.
Yeah, thank you for joining us for this discussion with Dr. Parikh. If you would like to learn more about the renal biopsy adequacy crisis, you can listen to our previous episode on this topic on YouTube or Spotify. Stay tuned for more episodes and follow us on social media to be a part of the conversation. Our social media handle is @Arcana Labs on Blue Sky and Twitter. Thanks again for joining us. We'll catch up with you on our next episode. Thank you.